Good morning, everybody, and welcome to the South London Regional Anaesthesia Workshop for 2021. I'm so sorry that I could not be there with you in person, but I'm hoping that you guys are going to have a fabulous day. In fact, I'm sure you will do. So I'm here to talk to you this morning for the first 30 minutes on the fundamentals of regional anaesthesia and also talking about Plan A blocks. I do have some disclosures, none of which will impact my ability to deliver this talk. I will be using QR codes during this presentation. So again, simply hold up your phone to the QR code to take the link, but don't worry, you don't need to worry about taking screenshots because I have already posted my slides on this SlideShare link. So this is the only QR code you'll need to get a picture of because the rest of the QRs will be on that slideshow link. Before I start, I really do have to say a massive thanks to Simon Fitzgerald and Anne Barron, two previous fellows of mine who are doing amazing things now in the big world, and also to their people that have helped them, Matt Sinnott and Peter Daum, who have helped them do a lot of work behind the background to put together what I'm hoping will be a really fantastic and successful course for you guys. So thank you to all of them. I'm very proud of you and good luck for today. So I guess my talk is a little bit like a football game in that it's in two halves. The first component, first half, I'm going to be talking about basic ultrasound and needling principles. I'll be focusing on the probe, the machine, ergonomics, needling, and sonoanatomy. And in the second half, I'll be talking about Plan A blocks. So why did we come up with the concept of Plan A blocks? What are the blocks? And talking about some of those key structures. Now, I only have 30 minutes, so let's get cracking. The truth is that many of you guys are already familiar with ultrasound, and many of you are using ultrasound in your daily practice already. And certainly if you've done a list with me, you may recognize a few faces. It's not unusual for people to get the ultrasound machine out. And clearly ultrasound guided regional anesthesia is that ability to take your technical skills using certain pieces of equipment and having a background understanding of anatomy and sonoanatomy. So when you fuse all of those together, that's how you're able to deliver ultrasound guided regional anesthesia. So let's start off now by talking about the probe. There's clearly a whole host of probes that you could use. You could use a high frequency probe, so probes with generate ultrasound greater than 10 megahertz. They're great at looking at superficial structures and they get great resolution in those superficial structures. Alternatively, you can use a lower frequency probe to look at deeper structures. They're better at penetrating. They tend to be curved array probes like the one on the right hand side of the screen here. So broadly speaking, for regional anesthesia, you're either using a linear high frequency probe or a curved array low frequency probe. Now, these are some old slides because the daughter that's pictured here is now 12 years old. So these are at least 6 years old, these slides. Don't hold the probe like this. I see people hold it like this. There's literally no reason for you to hold the probe like this. Regional anesthesia is a form of artwork. Certainly, I think it is. So therefore, when you're holding your probe, treat it like a paintbrush. You'll see that I opt for the two pictures on the left. I opt to use my pinky finger as a tripod, so I can use my finger to stabilize myself against the patient. But if you've got slightly smaller hands, and again, the picture on the far right here is my youngest daughter's, or my eldest daughter now. She was 6 at the time. Her hand holding a linear probe. That's a decent sized probe there. Hold the probe low down. Keep it nice and stable and brace yourself against the patient's skin. So keep that thing that you're going to be used to creating these beautiful images like a paintbrush. So you often will have heard of this acronym PART, dealing with some of the ways that we manipulate probes. It's slightly contentious now because those who practice POCUS use slightly different terminology, but in the interest of keeping consistent, I'll go through what PART relates to. The first is pressure, and that's literally applying an even pressure along the area that you're scanning. And avoid that dropout. That dropout you often get when you see people are not evenly placing the probe on and you get an incomplete picture. Make sure you use enough gel, not too much gel. Now, clearly, there's a point if you apply too much pressure when you occlude the veins. There's a happy medium between applying a decent amount of pressure to get a good image. Sometimes you can perform a block with the veins compressed, but it's important that you should know where they are. Alignment, or also known as sliding, is the act of sliding and tracing a structure up and down a limb, for example. It's important that you apply a slug trail of gel so that you don't get to a point where you're dry scanning. But this is literally that ability to scan up and down in real time and trace something. It's often useful if you're putting an arterial line in, for example. You can chase the dot by using alignment, or if you're scanning the median nerve along its path in the forearm, or the popliteal fossa looking at the sciatic nerve. That's alignment. Rotation is something people often do unintentionally. That's where you literally rotate the probe on the surface. Now you can use it, and I'll refer to it a little bit later. You can use it intentionally to help you find the needle, but this is something that's not often used intentionally. And lastly, tilt. A tilt is a useful maneuver, and it literally is involving changing the direction of the fan of that ultrasound beam. And the reason that's useful is because of this whole concept of anisotropy or anisotropy. What do I mean by that? Well, if the ultrasound beam hits the target of interest at 90 degrees, all of the beams get reflected back, and you get a lovely clear image. If, however, your ultrasound beam does not hit that the target of interest at 90 degrees, the angle of incidence equals the angle of reflection. So a certain degree of the ultrasound beams will be reflected away from the probe, so you do not get a clear image. And some of the best examples of this, only the peripheral nerve, so median nerve, for example, in the forearm, but certainly the sciatic nerve in the popliteal fossa as the tibial and common perineal nerves. These really demonstrate that whole concept of anisotropy. So that's talked about a bit about the probe. What about the machine now? Now, clearly, we've got lovely machines nowadays that have some presets. So when you turn on a machine, and I cannot stress to you enough, first of all, know how to turn the machine on. But once you've learned how to turn the machine on, use the correct preset. I can count the number of times that I walked into rooms and people have been struggling to do a block, and I look at the preset and it's been set to vascular or carotid or something. So select the correct preset for the area that you're blocking. Most of the time, there'll be a nerve preset. There may be small parts, MSK, or even spine if you're looking at the spine. Then it's really important that you think sensibly about what you're looking at the screen. What we don't want to do is to be in a situation where you're wasting screen real estate. So if you're looking at something that's really just featured in the top part of the machine, clearly maximize the view, reduce the depth so the area that you're looking at is focused within the main body of the screen. And you can see there, we've now reduced it from 10 centimeters to 2.5 centimeters. It's much clearer. The other thing to think about, once you've put the probe on, you're holding it correctly, you've got an image, is using the gain. Now, often you need to turn the gain up a bit, but many of the modern machines now have an auto gain function. If you're feeling really flash, there's either a manual or a digital time gain compensation. So you can increase the sliders and that sort of orientation along the screen. The other thing to think about is many of the machines now give you the ability to adjust the focal point. And clearly the focal point is a bit where the ultrasound beams are the most focused. So you want to adjust that focal point to the bit where you really want to see clearly. Now, the other thing we talked about this already, the ultrasound beam gets attenuated the further it travels. Now, clearly high frequency ultrasound travels a short distance before the beam gets attenuated. Lower frequency travels much further. So attenuation is directly proportional to the frequency. So again, when you're thinking about the frequency to use, when you've collected your probe, you're holding it correctly, you've got a lovely image on the screen, you need to think about whether you're scanning something superficial or deep. If you are scanning something deep, use a penetration preset or lower frequency range. If you're looking at something super superficial like an ankle block, use a resolution setting or high frequency range. Again, I cannot stress enough how important the color Doppler is. So using Doppler allows you to identify vessels where you may not otherwise realize that they were there. And clearly veins are compressible, non-pulsatile, hypoechoic structures, and arteries are non-compressible, pulsatile structures. Again, so veins you can compress, they do not pulse. Arteries are non-compressible and they do have a pulsatile component to them. Now, of course, these machines are not that clever. The color determines about what the blood is doing with relation to the probe. So blue is blood flowing away from the probe, and it's colored red if the blood is flowing towards the probe. And it's really useful every time you're about to do a block to turn the color Doppler on. As you see here, this is this is a long time ago now, but doing a supraclavicular block, you can see there's a suprascapular artery passing right within the substance of the supraclavicular brachial plexus. Okay, so we talked about the probe, we talked a bit about the machine. What about imaging? So clearly there are two different ways that you can generate an image, broadly speaking, with ultrasound. You can take a short axis view, often abbreviated to SAX, which is a cross-sectional view, or a long axis view, which is a longitudinal scan. Again, some really old images here, but this is a short axis view of the median nerve in the forearm. You can see the nerve as a cross section there. And then if we rotate the probe through 90 degrees, you get a long axis view of the median nerve in the forearm. So you can see the nerve along its length. So broadly speaking, those are the two types of images that you may get. Now, what about ergonomics? And I will talk a lot about ergonomics. If you've been a fellow of mine in the past, or you will be in the future, I will not apologize for talking about it, but it's important. So this is an example of Dr. Barron demonstrating bad ergonomics to us. That she's standing up, her arms are mobile, her head has to move to look at the screen and then to look at where she is. And again, her hands are going to move relative to each other. So that is bad. So she thought, you know what, I'll have a seat. So she sat down, but look at this, she's still having to look across at the machine and then down to where she is, and she's got no idea where the needle is. She's needling toward herself. So this is bad ergonomics. So Dr. Barron then thought about what she was doing. She thought, aha, now if I sit, so I can now align myself, so I'm looking at the machine, and I can look where my hand is, I've got my hand stabilized, got minimal head and neck movement, that's great ergonomics. So think about your ergonomics whenever you're sighting a block, because I guarantee your blocks will be more successful if you think about ergonomics. On that subject, here is a paper that was just published this year in Anaesthesia, some ergonomic guidelines. Please do scan that QR code and check them out. They cover a lot of the issues, as well as many more that I've discussed here. Okay, so we've now got the probe, we've now got great imaging, we know how to use a machine, we're sitting correctly. How do we needle? So this is my one dad joke for the thing. This is me needling in plane and out of plane. I thought it was funny. But anyway, let's talk about our needling. So here we've got a short axis view of the median nerve, and we're needling in plane. We're bringing the needle in across into that view, and we see the needle along its whole length. The other alternative is we take a short axis view of the nerve and we needle out of plane. And when we needle out of plane, of course, we don't see the needle along its whole length. We just see a cross-sectional view of the needle, and that appears as a dot. There's a hybrid maneuver here where you do a long axis view of the nerve, and you also needle in plane. That's quite a specialist technique, and it's often used for sighting catheters, or can be, but it's quite tricky. So again, let's go back to out of plane needling. So that's similar to what many of you will do for central lines. Now, of course, the one issue with out of plane needling is you think that you're looking at the tip of the needle, but actually it's possible that you're looking at the shaft and not the tip. So there's a few things that you can do to identify the needle, and hopefully you get a chance to practice that on the needling stations. But hydrolocation and using a steep angle, or inserting your angle a certain distance away from the probe, the same distance away from the probe as the depth that you want to get to, and going in at an angle of 45 degrees. But hopefully you get a chance to practice that. What about needling in plane? I've got to say, this is my preferred technique for many blocks. Needling in plane, it's all great. You've got a lovely view of the shaft and the tip, but it's not quite as easy as that, because sometimes it looks like you might be in plane, but actually if you look from above or from below, it may be that you've slightly veered off the central part of the ultrasound beam. Of course, that ultrasound beam is super narrow, about the width of a credit card. So it's really important that you line yourself up so that you're truly in the middle of that beam. Now, we've talked about, part, pressure, alignment, rotation, and tilting. What happens if you can't see your needle and you've got it inserted in plane? Are there any other things that you can do? Well, some clever people came around with reviewing the way that we use those probe maneuvers, and they came up with the STAR acronym. So what they mean is, right, see where the needle has gone through. So you can see where your needle has gone through the skin, that's the S. Then the next thing you're going to do is you're going to tilt the probe. Forgetting about the needle for now, you're going to tilt the probe so that you get the best view of the target structure, not the needle, the best view of the target structure. So see where the needle's gone through the skin, tilt the probe to get the best view of the target structure, and then use alignment to come now and find your needle. And once you've found the needle, if you are not looking along the whole shaft and the tip, use rotation at the end to see if you can isolate the tip and the shaft. And when they did this study, when they described this technique, they found that residents were much more likely to identify the needle tip in an in-plane situation if they applied these probe maneuvers in a sequential manner like this, rather than just think, oh, pressure, alignment, rotation, and tilting. So this is something to bear in mind. Now, again, there are two different ways that you can needle in plane. You can needle in plane along your visual axis, or you can needle in plane across your visual axis. So on the left-hand side over here, you see Anne is needling along her visual axis, and the right-hand side across the visual axis. That'd be the same as doing a popliteal static nerve block like this. So everything's beautifully lined up. I'm looking down the barrel of the needle and I'm looking at the screen, as opposed to turning sideways and kneeling across myself. Now, actually, when we've looked at some studies here, what it shows is actually needling along your visual axis makes more sense. It's a bit like trying to pot a ball, playing billiards or snooker or pool. You're much more likely to see what you're doing as opposed to needling across that view. So what now about safety? So we've talked about all these great techniques, but how can we make sure we're practicing regional anesthesia safely? Well, you may have been familiar with this single, double, and triple monitoring terminology. Single monitoring would be using ultrasound, or in the older days, using peripheral nerve stimulation only. Double monitoring is adding another modality. So either combining ultrasound and peripheral nerve stimulator, or adding some form of injection pressure monitoring. And then triple monitoring is using all three of those. Now, this is something that NYSORA had been talking about for a while ago, using those three different modalities to make your regional anesthesia as safe as possible. But why bother? Well, the truth is, unfortunately, ultrasound alone has not been proven to reduce the incidence of nerve injury, and we're probably never going to see those papers for a whole multitude of reasons. That's a lecture in itself. So one of the things to consider, and confession, I don't do this yet, but one of the things to consider is to use a peripheral nerve stimulator as part of your technique to be the brakes on the situation. So have it on in the background at 0.5 milliamps. You're not using the nerve stimulator to find the nerves necessarily. If you're doing the procedure and you suddenly get nerves twitching at a 0.5 milliamps, review where you are. It may be that the needle is much closer to the nerve than it needs to be. Make sure you're not intraneural. Withdraw ever so slightly. If you withdraw ever so slightly, the twitches disappear. You can administer your local anesthetic at that point. So that's something to think about. And it may be that you can use these techniques, but also you might want to consider assessing the injection pressure. There are a few commercially available devices on the market at the moment. The top one is a disposable component that you intersperse between your syringe and your giving set of your needle. And the other device pictured below is a whole new setup that allows for hands-free injection. So those are some options. But the other thing you could do is to use the compressed air injection technique, which involves putting a column of air above the local anesthetic injectate and compressing that column of air to 50%. So for example, you take a 30 ml syringe and put 20 mils of local anesthetic in and 10 mils of air above it, and you compress the air from 10 mils to 5 mils. What that will mean is that your injection pressure will never exceed 1 atmosphere, which is associated with causing damage when you're performing these techniques. Something to consider. In my personal hands, I would be anxious about getting air into the image and destroying it. So certainly something to think about. The other thing you could consider, and I do this, is self-injection. Now, clearly, I don't mean inject yourself, but do the injecting yourself. And there are a number of different techniques that have been described here. I use the Jedi, sorry, I don't use the Jedi, I use the Allen technique, which is pictured in the bottom right. The two that have been described are the Jedi and the single user. They've been published, and those QR codes will take you to those papers. And the Allen technique was taught by Tony Allen, is just transform the way I deliver regional anesthesia. And we've got a video with all of those techniques on that YouTube link over there. So consider doing that once you get good. Now we've got to no talk about regional anesthesia is complete unless we start talking about anatomy. So clearly the way that we used to learn anatomy has changed, and now many people are learning anatomy with a real focus on being able to deliver regional anesthetic techniques, and ultrasound has certainly helped us with that. So you remember the old days when you got this classic image of the brachial plexus, you got to draw. I get all of my fellows to do this. Well, it's worthwhile knowing about it because we can apply that clinical implications on it. You can start thinking about where you're performing certain blocks, and why certain blocks may be more better or maybe better than others when you perform a particular technique. So anatomy is really important. Now, clearly you've got to revise it. If you can attend a course where they've got cadavers, that'd be brilliant. Dig out your own textbooks and buy an app. And this is just a screenshot of my regional anesthesia folder on my phone. And I've got a number of different anatomy and regional anesthesia apps that are worthwhile investing in. Come and find me, drop me an email, and I'll discuss those with you in more detail. Why are these anatomy apps so useful? Well, look, you can start taking layers away and understand what's happening in a 3D component here. This is one that I'm using, Essential Anatomy. It allows you to highlight muscles and nerves and structures. You can highlight them, delete them, add them, isolate them, and it gives you so much of a clearer understanding of what's going on. So I cannot stress to you just how important one of these apps is. So ultrasound anatomy is sonoanatomy. Sonoanatomy is ultrasound anatomy. So there's a couple of rules that are worthwhile remembering. When you're looking at proximal neural tissue, tends to be very dark, tends to have a hyperechoic rim and then sort of dark hypoechoic content. So if you look at the proximal interscalene, you can see those neural structures are visible like that. But as you go more distal, as you collect more connective tissue, you tend to get this hyperechoic rim, but with a honeycomb content. And this is an example here of the musculocutaneous nerve, a very large musculocutaneous nerve lying in the arm there. So that's kind of a classic nerve appearance. But what about other tissues? So over here, if you have a look, adipose tends to have a relatively consistent sort of streaky appearance, but you can tilt the probe as much as you want. It pretty much looks the same. Adipose does not change in appearance with probe tilt. Whereas if you think about muscle, and the next layer here is muscle, that looks very steak-like. As you change the angle of the probe, if there's more than one set of muscle fibers or more than one muscle group, you'll see the fibers kind of change in direction over each other, and the intensity of the structure changes with tilt. That's one way of distinguishing adipose from muscle. And what about bone? Is the next thing over here. So you get a bright white line with high acoustic impedance, and then you get this dropout artifact where you cast a shadow below that high acoustic impedance structure. So that's relatively straightforward. And of course, you've got other structures such as pleura and blood vessels, which you will see when you do your scanning. So sonoanatomy often relies on cross-sectional anatomy. And what we often do, we'll take a schematic and use that schematic to apply pattern recognition to real-life ultrasound. So a type of schematic of the interscalene might be something like this. There are two oblong-y type structures, the anterior scalene and the middle scalene, and a triangle over the top, the sternocleidomastoid. And when you turn your head to one side, the tip of that triangle will end up over the interscalene groove. So that's one schematic. Let's apply that to an ultrasound image. Here's an ultrasound image, right? Let's apply that schematic to it. There we go, sternocleidomastoid over the muscles. You can see C5 and C6, but actually there's a couple of extra structures in there. If you're really smart, you would have spotted the dorsal scapular nerve, the long thoracic nerve. That just emphasizes the point that you only look for what you know. So the more anatomy you learn, the more you'll be able to look out for. So I think there's probably time enough for me to move on to the next part of the presentation. Now, you will all be aware that the Royal College of Anaesthetists have written a 2021 curriculum. And actually within that, you'll know there are 3 stages of training. You guys will all, I'm sure, be in stage 3, but although there may be some of you in stage 2 of training. And each of these stages, or across the curriculum, there are 14 domains of learning. And amazingly, regional anesthesia is now one of those essential domains of learning. Each domain of learning has a high-level learning outcome. And for regional anesthesia, the high-level learning outcome, or HALO, is to be able to provide safe and effective regional anesthesia. Pretty all-encompassing statement. So each high-level learning outcome has stage learning outcomes, SLOs, and key capabilities. So what for stage 3, what is the SLO? It is to be able to deliver a range of safe and effective regional anesthetic techniques for upper and lower limb, chest, and abdominal wall independently. That's a really big deal. And actually, if you look at the key capabilities, they're listed very specifically as tailor your regional anesthesia for day surgery, manage regional anesthesia and analgesia in all perioperative settings, quite a big one there, and then perform chest wall, abdominal wall, lower limb, and brachial plexus ultrasound guided regional anesthesia independently. Quite a tall order. The question I would ask you is, can we teach or learn it all, especially when you look at what happens now with regional anesthesia across the country? We don't have a particularly uniform way of delivering education. So that is where Regional Anaesthesia UK have come in with their Plan A blocks. If you have not been living anywhere near the internet or any webinars, it's possible that you won't know what I'm talking about. So what am I talking about? Well, back in 2020, there was an editorial written in Anaesthesia by some well-known regional anaesthetists. And essentially, the strap line of that editorial was that it's really worthwhile now as promoting a few high-value Plan A blocks that allow more and more patients to get access to regional anesthesia. So we have split that down into different anatomical locations as proposed by the editorial, and we've picked a block to be the Plan A block for each of those. So for the shoulder region, interscalene; for upper limb below the shoulder, axillary; hip for femoral nerve for hip; adductor canal for knee; popliteal sciatic for foot and ankle. Very contentiously, we picked erector spinae plane for chest wall and the rectus sheath for abdominal midline. If you can come out of your training and you can do all of those, you've at least got a starting point, and we started you along a path to be able to deliver a broad range of regional anesthesia to lots of people. Some very clever people, at least one of whom is in the audience today, Anne Barron, have very kindly helped us to develop these regional anesthesia Plan A block posters. If you scan that QR code, you'll get taken to a high quality PDF document. We can have access to those. And there was also another editorial written in Anesthesia, which you can scan over here. This is by Turbit and Johnston, and just showing what value it could be to have everyone be able to perform those high value blocks. So let's talk about a few of these in detail. So again, interscalene. Most of you will, I'm sure, have a chance to have delivered an interscalene brachial plexus block before, and these posters go through talking about the osteotomes as well as the dermatomes. And if you have a look here, this is the image that you will generate, very classically sandwiched between the scalene muscles, the C5, and often a very bifid looking two components to it, C6, and deep down you'll see C7, the vertebral artery. I really hope you guys get a chance to scan that later on today. Then you've got one of my favorite blocks to teach in the whole world, the axillary brachial plexus block. If you look at this image on the right hand side here, and we blow it up, you see this classic view of the conjoint tendon, which tells you are proximal enough in the axilla when you're performing the block, and that's the confluence of teres major and latissimus dorsi. So you can see that conjoint tendon right underneath the vessels. You know you're proximal enough, and you may well generate an image that looks very much like this. Wouldn't it be great if they could color code it? Erector spinae plane block, again, as a block that's become very, very popular, and you get this classical appearance. What I want to point out to you, when you start to get good at looking at these muscles, you will identify that the rhomboid muscle, that middle muscle layer, actually tapers off usually somewhere between T5 and T7. Below that level, there is no rhomboid muscle. So something to keep your eyes out for. The Rectus Sheath block, again, a really great block, and has shown a lot of increased utility now. Again, to emphasize that tram line appearance of the posterior rectus sheath and transversalis fascia, and you see that above the arcuate lines. There's a point within the abdomen where you've got, below that point, all of the aponeurosis of the abdominal wall muscles pass above the rectus abdominis muscle, and that's below the arcuate line. Above the arcuate line, there is a posterior rectus sheath. Below the arcuate line, there isn't. So hopefully, where you've got both the posterior rectus sheath and transversalis fascia, you will see this lovely tram lining. Femoral nerve block, many of you will have had a chance to have performed already. Again, to emphasize, the femoral nerve is often really hugging the iliopsoas muscle. So it's not always this classical triangular shaped structure that you think you're looking at when you're looking at it. And hopefully you'll get a chance to scan that again later on today. Really topical, really popular now. The adductor canal block has really been used a lot for knee surgery. And the big point of contention here is, do we call it the adductor canal block when we're actually not doing it in the adductor canal? We're most often not, or more often than not, doing it at the apex of the femoral triangle. I know if Dr. Erskine is in the audience, he will point that out to you when you're going around on the stations. But clearly, there's a few ways that you can make sure you are at the apex of the femoral triangle. And one of the main things you can do is to scan sartorius and scan distally until you point, so you see the point where the medial border of sartorius actually abuts the medial border of adductor longus, and that's the apex of the femoral triangle. Again, something to look out for in your stations. And then, of course, we've got the popliteal sciatic nerve block here. Again, a really lovely and simple block you can do in patients of all sizes, and you get a classic view like this. Now, when you're doing a scan like this, you're passing your probe up and down. You can see this little animation I've done here as the probe's going up and down in the neck, looking at the interscalene region. You've got lots of things to potentially identify on your way down. You can hopefully see C5, C6, the superior trunk. And this is wonderful. So when you generate this view, how do you know what it is that you need to identify? And how do you know you're doing it properly? Well, you got this, or rather we got you, because we thought about this, and there's just been a very recent publication in Regional Anaesthesia and Pain Medicine where we've looked at the Plan A blocks and said, right, there are two phases of scanning: the orientation view, where you're trying to find out where you are and identify structures, and the block view, which is the final structure you've got on the screen as you're about to stick the needle in. And what we've done is we've come up with a number of recommendations for the structures that you really must identify at each of those phases of scanning. So please do check out that paper. It's available from Regional Anaesthesia and Pain Medicine. If you can't get hold of it, give me a shout and I'll share it with you. But this is where you'll have an idea of the structures that this large number of experts in regional anaesthesia have thought these are the structures you must identify when you're performing these blocks. The other thing I wanted to point your attention to is some great online resources. There's a number of YouTube channels here which I use a lot. The top one is the Regional Anaesthesia and Acute Pain Medicine from Duke Anaesthesia. They were responsible for a lot of the Blocktober videos. Check them out. Ki-Jin Chin, if you haven't heard him, you haven't been doing regional anaesthesia at all. He's a brilliant speaker, lecturer, and educator. So please do check out his channel. RUK, we do have some videos on there that go back quite a while, and some that I've done more recently, and then NYSORA as well. So check out those channels. Finally, I do have to talk about stop before you block. Wrong-sided blocks are still considered to be a never event. But things are going to be changing, and early in the new year, there's going to be a new policy, a new process called PrEP Stop Block coming out. But the basis of this is that we should not be given our needle until we've stopped to check before we're doing a block. But there's a whole host of educational materials that will be coming out early in the new year of 2022. So watch out for that. But in the meantime, between now and then, please make sure you do something to make sure that before you stick that needle in the skin, you are blocking the correct side. So that brings us to the end. Let me summarize. Make sure you hold your ultrasound probe properly. Understand how to use the machine. Learn how to turn it on. Use the right preset. Use the correct frequency and gain and depth. Think about ergonomics for success. Take care when you needle. Try to needle along your visual axis and needle in plane. Learn your anatomy. And when you're doing your blocks in real time, start off with a Plan A blocks and use those resources that are out there. Many thanks for listening. These QR codes will take you to my slides and to my YouTube channel, where I will be releasing this video shortly. Many thanks, take care, and enjoy the rest of the day. I do have to mention very quickly that next year, 5th or 7th of May, we will be hosting our UK joint meeting with NYSORA in Edinburgh. So do come and check us out. Many thanks. Bye-bye.